Now, we're going to move on to RV failure management. Hopefully at this point, you're a little freaked out because this sounds very scary, but don't worry because be zen. We are going to work through how we're going to manage these patients. And we're going to keep it simple because in certain ways it's complicated, but if you break it down, it's really not that complicated. So we're going to go through our 5 steps to RV rescue. Step number 1 is be very careful and cautious with fluids. Step number 2 is decrease your RV afterload. Step number 3 is support your systemic blood pressure. Step number 4 is support your RV contractility. And finally, step number 5 is be very, very cautious with intubation. Let's start with step number 1, careful with fluids. So this addresses this part of our spiral of death, that as the RV volume starts blowing up, it's increasing oxygen demand, it's giving you RV ischemia, and simultaneously shifting your septum, increasing your LV EDP, and dropping your LV preload. And if we fluid load the RV, we're making this whole problem worse. Because remember, if your primary problem is that your pipes are blocked, which more often than not, that's your primary problem. I mean, problems causing pressure overload are way more common than isolated RV MIs. Those are very uncommon. So the majority of the time you're having a problem with the RV, it's going to be some version of your pipes are blocked. And these patients, they often need diuresis. And they often need a lot of diuresis because the RV, its Starling curve, if you look at it, is actually a lot flatter than the LV Starling curve, meaning that once it's overloaded, you really often need to take a lot of volume off before it starts getting better. But there's another problem that often comes up because often these patients need aggressive diuresis, but often they'll have acute kidney injury when they come in because they're in cardiogenic shock, they're cardiorenal syndrome. And so then everybody loses their mind because they're like, well, they have an acute kidney injury, the creatinine is 3, so I can't possibly diurese them. Here's the thing. Don't forget, the kidneys do not like fluids or diuresic intrinsically. You know what the kidneys like? Perfusion. And the only way to improve the RV's ability to perfuse them when it's pressure or volume overloaded is by giving diuresis. That's what the kidneys want. They want perfusion. And keep in mind that if the RV is truly pressure or volume overloaded, it's often going to be decreasing preload, that all that volume is actually paradoxically decreasing your LV preload. And what's going to actually increase your LV preload is offloading that RV so the LV can in fact fill during diastole. So, do I give fluids? In a patient where I believe that they have an isolated RV infarct, they're hypotensive, there's no reason to think that the RV afterload is high, I'll give some initial fluid boluses. But I'll keep in mind that ultimately fluids aren't going to fix that problem, and ultimately I may shoot myself in the foot if I give too much by causing that septal flattening. So I'll give some initially when I have a patient who is in cardiogenic shock due to an acute RV MI. But in almost all other cases, I will not give fluid. It will not help you. I'll start diuresis. Next, now let's talk about RV afterload. So this is princess physiology number 2, that the RV crumbles at the first sign of resistance, and this is how it plays out in our vicious cycle, right? That the RV, one of the primary determinants of RV contractility and stroke volume is afterload, right? And not only that, but high RV afterload contributes to ischemia. So we remember this graph, that the RV drops its stroke volume precipitously in response to increased afterload, and its perfusion too, right? So it's used to getting perfused during both systole and diastole, but now we're going to increase RV afterload. Our pressures go up and we drop those perfusion pressure gradients. This is causing RV ischemia as a secondary effect. Now let's take a minute and talk about what are we going to do about this? And let's go back to our 2 categories. We have obstructive and vasoconstrictive etiologies of increased RV afterload. What are we going to do about them? Well, thromboembolism. In terms of the obstructive etiology, what do we need to do? We need to get rid of the clot. Now, that's a whole different lecture when we talk about lysis and heparin. So that's a different lecture. But fundamentally, yes, we need to lyse the patient. We need to get rid of the clot, get rid of the thromboembolism. What about lung disease? Well, that one, we need to treat the underlying lung disease. Now, sometimes in patients who are having a COPD exacerbation, yeah, that's actually in a lot of ways not that hard. We'll give some steroids, we'll give some nebs, we'll try and do our very best to address their underlying lung disease. And, often positive pressure like BiPAP won't help the RV intrinsically, but if I think that the patient's real problem is that they're having a COPD exacerbation and I need to give them BiPAP to help that, absolutely treat the lung disease. Now, what about vasoconstrictive etiologies? Well, we have a couple low-hanging fruit things. We have our hypoxemia, hypercarbia, and acidemia. And I call them low-hanging fruit because of this. Remember our graph showing the relationship between increased pulmonary vascular resistance with lower oxygen saturations and pH? What this means is that fixing any one of these things, fixing the oxygen or the bicarb or the CO2, will disproportionately improve your PVR. So even if you can't fix all of them, fixing some of them will help you. Now, here's another question. Can't you just give some bicarb, right? I mean, we talked about how acidemia is bad and how that'll sort of help you if you fix the acidemia, so great, why don't you just give some bicarb? Well, it depends. If you have a patient who, let's say, has a massive PE, or maybe has some really bad lung disease, often those patients have a problem, and that is called physiologic dead space. So physiologic dead space happens when you have areas of the lung that are ventilated but not perfused. And so functionally what that means is that, they're ventilating, so you're getting the CO2 in and out of the alveoli. The problem is that the pulmonary capillaries attached to those alveoli, they're not really working. So the CO2 just passes right by because it can't get out into the alveoli. And so physiologic dead space is when you're moving all kinds of air in and out of that alveoli, but it doesn't matter because you can't get the CO2 to that alveoli to move out of the body. And in these patients, giving bicarb not only doesn't help you, but it can hurt you. Because the only reason bicarb works is you give the bicarb, it can convert it into CO2 and H2O, and you breathe off the CO2, right? That's how it works. If the patient has profound physiologic dead space and can't breathe off the CO2, all you have done is convert your metabolic acidosis into a respiratory acidosis and got yourself precisely nowhere if they have a condition where they have lots of physiologic dead space. In addition, if you're giving bicarb, you have to remember, it's not just the bicarb. Giving a bicarb bolus, it's a big fluid load. Bicarb's really hypertonic. So you're simultaneously loading the right ventricle with a bunch of volume. And if your problem is a pressure overload problem or a volume overload problem, you haven't done anything useful for yourself. So just giving some bicarb, probably not really going to fix your problem, especially if it's a situation when the patient has some kind of lung or pulmonary embolism thing going on, that they have a lot of physiologic dead space. Now, in terms of these physiologies, you may have also noticed that a lot of the time you can't always fix them immediately. It takes a while to lyse somebody. Some of the lung diseases mean that you have physiologic dead space and you maybe can't get their acidemia better. Or, maybe they have interstitial pulmonary, interstitial disease. Maybe they have IPV. Maybe they have fibrotic lungs, and that's not really something you can fix. And often, as we just talked about, it's not that straightforward to fix the hypercarbia and acidemia, especially not immediately. So these are the times that we now have inhaled pulmonary vasodilators to the rescue. Because if you're getting into those situations that the lung disease is bad, there's not a lot you can do about it, they're getting more acidemic, pushing bicarb won't help you, we maybe need an exit strategy. And this is where these guys get super useful. And there's two things they do for you. The main one that they're doing for you is pulmonary vasodilation, but they also can help you with VQ matching. So in terms of the vasoconstrictive etiologies, they help you with all of them, because they're a direct pulmonary vasodilator. And so whatever is causing your pulmonary vasoconstriction, they just straight up vasodilate it and try to override the effects of hypoxemia, hypercarbia, acidemia, and inflammation, going straight to the source, just overriding it, vasodilating. If you have somebody with primary pulmonary hypertension, certain subtypes of this, it's the same idea with giving nitroglycerin to a patient with systemic hypertension or any antihypertensive to a patient with systemic hypertension, except you're selectively delivering it to the pulmonary circulation. So it's going to help your primary pulmonary hypertension patients often as well. Then we have our patients with lung disease and thromboembolism. So in patients with thromboembolism, why is this going to help you? The reason this is going to help you is because with thromboembolism, it's not just the obstructive effect, it's also the inflammatory effect. And so helping that inflammatory effect with a direct pulmonary vasodilator can buy you time, because it's a lot faster to start an inhaled pulmonary vasodilator than to lyse the patient, because even once you give the lytic, it takes a while. And lung disease, right? If you have somebody with bad lung disease, and either, it's a maybe fibrotic disease that you can't fix, or maybe they just have really bad physiologic dead space, so you can't get that CO2 off, you can't correct the acidemia, it'll help you there as well. And so it'll really help you correct those etiologies, directly vasodilate, and correcting all of those etiologies will help you then correct all these etiologies. So this can be a very useful thing to do on so many levels. Now, what drugs are these? Well, the technical ones, the sort of on-label ones, shall we say, are epoprostenol and nitric oxide. Now, if you don't have access to these, because many of you don't, especially in the ED, that's okay, because we can use common drugs that we have just using one of those masks that you would normally use to give albuterol. So you can either use milrinone, getting the 1 mg per ml concentration and have them inhale 5 milligrams over about 15 minutes, or you can use nitroglycerin. Same idea, if you can get the 1 mg per ml concentration and inhale 5 milligrams over 15 minutes. These things you have in your ED, and you can learn to use them, because as we just talked about, inhaled pulmonary vasodilators in these patients can be very, very helpful on so many levels in so many disease states. Next, now we're to the management step of supporting the systemic blood pressure. And this, in fact, is one of the reasons that inhaled pulmonary vasodilators are so useful, because you need to support that systemic blood pressure, but we'd kind of like to not drop our systemic blood pressure by giving a vasodilator, but we do want to drop our pulmonary pressures, so just giving them inhaled, where they're just inhaled, they're just delivered to the pulmonary circulation. That's another advantage of doing that way. Now, why? Why do we care so much about supporting our systemic blood pressure? Well, it has a lot to do with princess physiology number 3, which is that it feels entitled to constant perfusion. So that's this part of our vicious cycle. Our RV is getting ischemic because we've dropped our MAP, we've dropped our coronary perfusion pressures, and this is often the thing that sets off the vicious cycle, is you already have an RV that's hurting because maybe the afterload's high, it's losing contractility, but it's kind of hanging in, but then the MAP drops, you drop its perfusion, it gets ischemic, and everything falls apart. So remember, normal day, it gets perfusion during both systole and diastole. And when you drop your MAP, you really get in trouble because now you've dropped your perfusion pressure and the RV's not getting all that perfusion it feels entitled to. But this is another adding insult to injury situation. Because if you take a situation when your systemic pressures are low, your perfusion pressure is already suffering, and then you simultaneously increase your pulmonary pressures, you increase your afterload, and now you have high pulmonary pressures, now you've taken a double hit and you've dramatically dropped your coronary perfusion pressures, and your RV can get ischemic real fast. So, especially in the situation of high RV afterload, it's really important to control that blood pressure and to aggressively support that systemic blood pressure. But wait, you say. Okay, you just told me that I really need to aggressively support the systemic blood pressure, make sure they don't get hypotensive, but you also just said earlier that giving a bunch of fluid is not a good idea in these patients. So what am I supposed to do here? Well, this is a pressors for the win situation. Pressors are your friend, but which one? So if we're talking about pressor and vasoactive choice in RV failure, the underlying principle is this. What you want to do is you want something that's going to support your systemic vascular resistance and bring up your systemic vascular resistance without constricting your pulmonary vessels. What you don't want to do is increase your pulmonary vascular resistance, because that may be your problem in the first place, and it's not going to help you to do that. So what we need to find is we need to choose a vasoactive that's going to increase our systemic vascular resistance without increasing our pulmonary vascular resistance. So let's look at our vasoactives. And a really great choice for this can be vasopressin. The nice thing about vasopressin, it increases your systemic vascular resistance and has almost no effect on your pulmonary vascular resistance, so it can be a good first line. Epinephrine also is a good first line because it'll support your systemic vascular resistance, but because it has both alpha 1, as well as beta 1 and beta 2, that beta 2, especially at lower doses, balances out that alpha 1. So at doses of less than maybe 20 mics per minute or so, that beta 2 is favorable, and you get really nice systemic vascular resistance increase without a ton of increase in your pulmonary vascular resistance. In addition, it can help support your RV contractility, which is the next step. So epi is also a really good first choice. Norepi, as always, follows the law of norepi, which is it's not always the best choice, but it's rarely the wrong choice. So the difference between norepi and epi is that norepi doesn't have that beta 2 to balance out that alpha 1, so you're going to get a more increase in your pulmonary vascular resistance than you would with epi and certainly with vaso, but it's still a relatively favorable profile. Now keep in mind, as you go up and up on the dose, that becomes less true. So it's not my first choice, but would I start norepi over giving fluids? 100%. And often at first, you just need to give something. So norepi is, again, not my first choice. Epi is probably my first choice, maybe vaso, not a totally unreasonable thing to do, but often you find yourself needing to switch to something else. Phenylephrine, not a great choice. Doesn't do very good things to your PVR to SVR ratio, not a good choice in pulmonary hypertension. Dopamine. So I don't really like dopamine for almost anything, and including this, because not only does it not do good things to your PVR to SVR ratio, you also now are at increased risk of tachydysrhythmias, which helps you none at all. Dobutamine. So dobutamine can be a good thing because it supports your RV contractility. It actually improves your pulmonary vascular resistance. It vasodilates the pulmonary circulation, but it also vasodilates the systemic circulation. And so you just have to watch out for systemic hypotension. So that's why it's usually not the first thing that I'm starting, because I need to support my systemic blood pressures first. And the same goes for milrinone. So the right ventricle and the pulmonary circulation love milrinone, because it vasodilates the pulmonary circulation. It supports contractility of the right ventricle. It's not that tachyarrhythmogenic. It's great, except it also vasodilates the systemic circulation. And so in a patient who's profoundly still systemically hypotensive, it's not going to be my first choice. That being said, I'll often add it on later once I've stabilized the systemic blood pressures, and maybe now the case is that my patient's just not diuresing well, and I sort of have them stabilized, but their lactate's still high, they're not perfusing. That's often when I'll start milrinone, IV. Now, as we talked about, inhaled milrinone is another story, because inhaled milrinone, the beauty of this is that you get pulmonary vasodilation, but you don't drop your systemic blood pressure. What you're missing with the inhaled milrinone is the contractility support, that your milrinone inhaled, it's not systemically absorbed, so it's not going to help your RV contractility. Now, another question that I get a lot is, what's my MAP goal in these patients? And the answer is it kind of depends how high I think their PA pressures are. Because conceptually, another thing I'll get concerned about with really high PA pressures is that I want to keep my mean PA pressures very far away from my MAP. Now, partially this is for perfusion reasons, but also it's partially just for, if you think about it, flow in our circulatory system is completely dependent on pressure gradients. So conceptually, if all of a sudden I completely equalized my PA pressures with my systemic pressures, I don't have a lot of flow here, right? I am now missing a key pressure gradient that I need to literally keep things moving. And the magic number seems to be about 2/3, that things are sort of starting to fall apart when your mean PA pressure gets to be greater than 2/3 of your MAP. Now, you're very reasonably saying, well, I'm not measuring a mean PA pressure in the ED, because how on earth am I going to do that? And I don't have a swan all the time in the ICU. So it can be helpful if you do have some data on your patient. And if I know that my patient's most recent PA pressure, either on ultrasound or even better on a right heart cath, was, 80s over 50s, I'm going to want to drive my MAP up a little bit more than I otherwise would. So if I think somebody's having really high PA pressures, I might want a slightly higher MAP. But the more important thing is to prevent it from going low, because transient hypotension in these patients can be very problematic because it can set off that vicious cycle of hypoperfusing your right ventricle. Now, item number next on our steps to RV rescue, which is improve RV contractility. So that's this whole problem, right? That for whatever reason, your RV contractility is down. That causes a drop in your RV cardiac output. It increases your RV volume because you can't move anything forward. So helping support the RV contractility is a good thing. But at the same time, it's useful to optimize the RV afterload and RV perfusion before addressing contractility. And so that's why I like to start vaso and then maybe a little low dose epi to sort of optimize my map. And then if I can, an inhaled pulmonary vasodilator, because sometimes the problem isn't that your RV intrinsically is down, it's just that it can't push against the afterload. And so that's often why I'll start sort of milrinone or maybe dobutamine later in the patient's course. But if you're going to do this, epi is a good first choice because epi will simultaneously support your map, support your perfusion, support your contractility without increasing your pulmonary vascular resistance. You can also use dobutamine or you can use milrinone. Keep in mind also milrinone's longer acting, so you need to be a little more thoughtful, and I'm less likely to start it in the ED than ICU, but sometimes, especially if just you've supported the map but things aren't moving, the patient's not diuresing, they're not getting better, milrinone can be a good thing to add on once I've done my pulmonary vasodilator and I've supported the systemic blood pressure. And last, be very, very careful with intubation. The real question in these patients is, do you actually need to be intubating them in the first place? Like everybody wants to talk about how to safely intubate them. That's not the right question. The question is, why do you think you need to intubate them at all? And this is part of what I like to call the respiratory failure masquerade. Now, of course, some of these patients are truly going to present in respiratory failure because maybe they have RV failure because of their COPD or because of their interstitial lung disease. But a lot of the time, respiratory failure can masquerade because patients in shock, in cardiogenic shock, can look like respiratory failure. Why? Because they're tachypnic. They say they can't breathe because that's what the body does when it's in shock. Often their O2 sat will look bad, but not because they're hypoxemic, but because their O2 sat waveform is not good because they're not perfusing their fingers. And the key thing to keep in mind here is that especially for patients like maybe with a massive PE, but patients with RV failure, what kills them? In a patient, for example, with a massive PE, they're not dying of respiratory failure. They're dying of hemodynamic collapse. And so just because they're tachypnic and tachycardic doesn't mean that intubation is going to fix their problem. Because unless you really think that the primary problem is a primary lung problem, which sometimes it is, but if they're hemodynamically unstable from RV failure, that is your biggest problem. And the issue is intubating these patients can be very dangerous. Because if you look at our vicious cycle, intubation is a great way to put us into it. Why? Well, what do you do when we intubate patients? We make them hypotensive. We, one, give them induction agents, and two, once we do that, we pull out their own sympathetic drive right out from under them. Because these patients are often highly sympathetically activated. They can't breathe, so their endogenous epidrip is going bananas. You make them hypotensive, that drops their map, it can set off the cycle. What else are you doing? You also often are making them hypoxemic and hypercarbic during intubation. What does that do? Increases RV afterload. Then again, to add insult to injury, once you successfully got them induced and intubated, you then put them on positive pressure ventilation, which also increases the pressure in the chest and increases RV afterload. So intubation is a fantastic way to put somebody into the RV spiral of death. And in fact, this was a study that looked at patients in the OR doing a planned, but emergent, but planned pulmonary embolectomy. In the OR, with a planned surgery, 19% of those patients coded on induction. So if that's what's happening in the OR, you can only imagine what's happening when we're doing this sort of off the cuff emergently in the ED or the ICU. So intubating these patients is dangerous. It's a bad idea. It can be very hazardous, but what if I really need to intubate? And sometimes you do. Maybe it's because their lung disease is your primary problem. Maybe it's because, you're putting this patient on ECMO for their PE, but what if I really need to intubate? So if I really need to intubate, okay, this is a whole lecture in and of itself, but the bottom line is this. One, cardiostable induction. This is probably not the time to be pushing 200 of propofol. Pick your cardiostable drug, but again, just nice cardiostable induction. The other best way to make sure that happens, of course, is pressors on board. And I don't mean like somebody has a bag of epinephrine out in the hallway and nobody can find the pump. I mean like The patient is connected to the epinephrine drip and it is going. Because remember, making these patients a little extra hypertensive is not going to hurt them. It's not like LV failure where you're worried that things are going to fall apart if you make them too hypertensive, because your RV afterload's your pulmonary vascular resistance, not your blood pressure. So I have pressors running. I will start epi. I will start vaso even if they're normotensive before I induce them. And I have push dose epi ready to go in my hand. Next, I will put them on a high flow nasal cannula. 1, for apneic oxygenation to try and prevent that from happening. And 2, if I'm really worried, I'll often just be delivering a pulmonary vasodilator through my high flow while I am doing this. Next, try and avoid hypercarbia. So this is a situation when, yes, you want to avoid hypoxia for sure. And I think often, when we're intubating, we're watching the SAT and we'll just make attempt after attempt as long as they're not dropping their SATs. And that, whether that's a fine thing to do on a normal patient is a whole nother conversation. But in these patients, remember, hypercarbia is bad. Hypercarbia causes increased pulmonary pressures. You're not helping yourself. So if for whatever reason you have the very unfortunate confluence of circumstances where they're also a difficult airway and you're taking time, you need to bag them. You need to avoid hypercarbia. And then lastly, be gentle with your positive pressure. This is not the time to give them a PEEP of 25. This is not the time to give them super high tidal volumes with super high pressures. And this is not the time to bag them like crazy once you're done intubating. You want to try and keep your PEEP on the low side if you can. Now, if the patient's profoundly hypoxemic or if they're morbidly obese, you might need some higher PEEP. But be gentle if you can. Give them a fast respiratory rate, blow off that CO2, and then, try and keep your peak pressures on the low side. Is this an easy thing to do? Not really. Intubating these patients can be a nightmare and a half, and the most important thing is to decide if you really, truly need to do it in the first place. So that is rescuing the right ventricle. We can now see why when our patient came into the ED off her flight with Thailand, how the sequence of events played out. How we gave her fluids and she looked worse. And why then when we intubated her, she coded. It now makes a lot more sense to us. So during this talk, we talked about the RV failure physiology, the key princess physiology of being easily offended by mistakes, crumbling at the first sign of resistance, and feeling entitled to constant perfusion. We talked about how that physiology all comes together with our RV spiral of death, and how that spiral of death can be set off by any of our etiologies. We talked about RV failure differential diagnosis, and how recognizing RV failure is half the battle, and how often common lab tests can lead you astray, and how we have to remember that the RV, unlike the LV, backs up into the abdomen, not the chest, and how we have to be very careful and thoughtful about how we interpret echo findings. In terms of differential diagnosis, we have 3 big categories: our pressure overload, our volume overload, and our decreased contractility. And lastly, in terms of management, we reviewed our key 5 steps to RV rescue, which is 1, be very cautious with the fluids, maybe give them some diuresis. 2, decrease your RV afterload with a pulmonary vasodilator, either of the traditional or non-traditional sort. 3, support your systemic blood pressure with a vasoactive that supports your SVR without increasing your PVR. 4, improve and support RV contractility. And finally, be very, very careful with the decision to intubate your patient. Thanks you guys so much for listening.